We are live.
Good evening, everyone. For today's session of iFocus, we will dive into the secrets of extracapsular cataract surgery, the various indications and techniques. And for this session, I would like to welcome our esteemed moderator, Dr. Sen Gupta sir, who has an extensive experience in cataract surgeries, and also our chairperson, Dr. Paresh Ved. Welcome, sir. Can we begin the session, sir?
Thank you, Dr. Garbita.
Thank you,
Dr. Garbita, for the introduction. So we are on to the 398th episode of iFocus Online, and this is the 12th session of the cataract module. And as Dr. Garbita told us, we'll be delving on extracapsular cataract surgery, indications and techniques. And we have none other than Dr. Tyagi to speak to us. She's a senior consultant at Center for Sight. She's a very well-known figure in the field of cataract and refractive surgery, and also a very revered pediatric ophthalmologist. It is my pleasure to invite Dr. Kanak Tyagi to speak on ECCE indications and techniques. Over to you, ma'am.
Thank you, sir. Thank you very much. I'll be speaking for this. Just a second, hold on. Just a second.
So as Dr. Tyagi gets ready, ECCE is something which is the basis of all the future techniques of cataract. Oh, she's ready. So we are ready to go. Over to you, ma'am.
Thank you, sir. Thank you for the introduction. And this topic, which I am covering, I know planned extracapsular cataract surgery is actually totally gone nowadays. It's very specific indications when we do this surgery. As the advancement in understanding and pathophysiology of surgical techniques, instrumentation, and with good pharmacological agents, cataract surgery has almost become risk-free. So as the fourth industrial revolution is going to be artificial intelligence, when machines will outperform a human level and enable us to reach the full potential in other ways. I've specifically told other ways because still the human intelligence carries the upper hand. And it is the alertness, awareness, and mindfulness, consciousness of a surgeon which makes him different from the artificial intelligence. So for a student, I always say, whenever you learn a cataract surgery, there are a few basic principles you should never forget. Know your interpupillary distance. Know your depth perception, because what we have experienced when we used to train the FACO or any students, we found out that few of the students didn't have their stereopsis and they never got it tested. So this two things as a pediatric ophthalmology, I want to emphasize that know your stereopsis very well. Third thing is posture. Whenever you are doing a surgery, learn to have a good posture, because what happens in a long term, when you don't learn to have a proper posture, you will start having difficulties. And whenever it is a complicated case, you will lose the concentration while handling that case. So good posture is very, very important. Then a good dilated pupil, which is necessary in cataract surgery. But nowadays, as we are doing all the complicated cataracts, you should at least know how much pupil dilation is available. And perfect analgesia and akinesia. These are the 5 key points which, when you start a cataract surgery, you should know it. Pre-op evaluation. It shouldn't be underemphasized, because today's patient, if you have missed even a single finding, that may cost you a very high post-operatively. So a thorough anterior and posterior segment examination or good IOL power calculation. I think everybody has been taught about IOL master and all. So a good IOL power calculation, which IOL has to be put, because in situation when you're planning to go for a ECC, it may be a complicated case. So you should have a standby intraocular lens. Mostly it is 3 piece. So these things have to be planned beforehand. It is not that in OT suddenly you land up with a case and you don't even have that standby IOL. And everywhere, all centers, all small centers don't have this standby 3 piece IOLs at time. And which viscoelastic has to be used, because while doing the surgery, which viscoelastic you want to use, that is very important, because if it is a hard cataract, you should specify that you need to use viscoat in this case. Or if it is a HMSC and you want to do a Rexis, even few people use heel on to maintain the chamber. So these things have to be specified pre-operatively. Other things, if you additionally need, is like iris hooks or capsular tension ring, that has to be specified. And pre-op medications, what you need to advise the patient separately, because as I told you, you won't plan a ECC in a normal cataract. It would be a complicated case where you're going to plan the extracapsular cataract extraction in 2 days. Then pre-op counseling of the patient, I have specifically written subjective versus objective. You might have seen everything thoroughly, you did a very good surgery, but you didn't explain to the patient, and you may land up with the problem. A simple a bit dilated pupil post-op because you have used iris hooks or something, or it was a non-dilating pupil, and patient may complain of glare or say the clarity is not good. So if you haven't explained the patient, you will land up in the problem. So objectively, if you have seen everything, you need to explain to the patient also whatever you are planning, why you are planning, what would be the post-op results. So this is very, very important in today's scenario when patients are very demanding. Then as the cataract surgery has evolved from couching, it was the ECC which paved the way to the modern day surgery. The major revolutions were leaving the posterior capsular behind, fine suture materials were available, the intraocular implants were available, incision size which kept on decreasing, and phacoemulsification. These were the few revolutions which really changed the scenario of cataract surgery. In today's scenario, extracapsular cataract surgery remains plan B to a successful phacoemulsification. So in which cases would you like to do extracapsular cataract surgery in today? It's mostly the conversion from routine phaco to ECC. In case of HMSC, when you start doing the case and you think the rexus is going out, or there is bit of phacodonosis or something, or while doing the cataract surgery, you notice a large PCR. In that case, you will change it to the extracapsular cataract surgery. Or large luxation in traumatic cataract. This would be a kind of a planned extracapsular cataract surgery. Or in case you were handling a hard cataract and suddenly you find the capsulorhexis has gone out, and then you plan for a ECC. So techniques of cataract surgery, it is now phacoemulsification, small incision cataract surgery, or femtolaser assisted cataract surgery. Intracapsular and extracapsular are practically in those cases where intracapsular is if it is a subluxated lens in an anterior chamber, then only you will take it out with this technique. Or extracapsular cataract extraction, as I told you, it is more of a conversion from phaco to extracapsular. So what are the 4 steps, basic 4 steps in extracapsular cataract extraction? It is the incision size, which is a very large incision. Capsulotomy, normally we do CCC in all our cases. But in these cases, because of the large nucleus, you may directly opt for kind of can opener technique. Then cortical cleanup. Normally we do a closed chamber wash. But in this case, you may have to use Simcoe cannula, in which the anterior chamber is very shallow and it is an unstable chamber in which you have to do the AC wash. and expression of the nucleus, delivery of the nucleus is a bit different. You have to take out the nucleus from the very large incision, because nowadays we are not used to all these things. So these are the bit different things which happens. And while aspirating also, if you are aspirating from a larger incision, there are chances that you may hold the posterior capsule. So these are the few things which are different from normal phaco surgery in extracapsular. Instruments, I have just shown this list. Just be prepared to keep all the instruments, because when you are doing daily phaco, then you realize the set doesn't have a superior rectus or something if you are daily going for a phaco surgery or a femto surgery. So if you know that this is a case where you can land up with the extracapsular cataract surgery, or you need to change it to SICS, so just be sure that you keep all the instruments ready. And like Simcoe cannula, you may be finding the Simcoe cannula has become very rusted, or it has not been cleaned for a long time. So these are very small things, because suddenly you realize once you have landed in a complication and your Simcoe is also rusted, it's not working well. So you have to check the instruments before starting these kind of surgeries. I would just like to highlight about the suture tying forceps, because they also have to be a very good quality suture tying. You will find that your needle holder is not there. Your suture tying forceps has been like very old. So just check for these small things, because suturing the wound is very, very now, like practically you lose the practice of suturing the wound, and you find the forceps are also not working. So these are very small things, but that make a lot of difference when you are dealing with the complicated cataracts. And this is a Simcoe cannula. I just want to give some idea about the Simcoe cannula. It is a combination of two cannula, in which one is the aspiration port, one is the irrigation port. The aspiration port is always on the tip of the cannula, and irrigation port is on the lateral part of the cannula. So normally what we do is we aspirate from this tip and irrigate from the lateral part of the cannula. It is a direct Simcoe cannula, but there are reverse cannula also. So incisions in cataract surgery are very, very important, in which like whether you are opting for a corneal, limbal, or scleral, practically if you will convert a phaco into a extracapsular cataract surgery, then you will start from a corneal incision. But if you are sure that probably there are chances, high chances that you'll have to convert, you can be a bit limbal also. And scleral practically is very less. We don't make a scleral tunnel, but if you can go for a kind of SICS, scleral incision is used. So whenever you are making a tunnel for phaco, and which you may extend to make a extracapsular extend it for this extracapsular surgery, always notice that if there is a filtering bleb, or there are like people nowadays are on blood thinners, and they are on two blood thinners. Normally one blood thinner like 75 milligram of aspirin doesn't make much of difference. But if patient is on two blood thinner and you have asked the patient to stop, so just check it all these. Don't go towards the limbal side, because that will cause problem. That will cause a lot of bleeding. At times, holding a conjunctiva causes so much of bleeding in these patients. So this thing you need to be very careful. Then and scleral incision, basically, it's more towards the limbus, Fuchs corneal dystrophy. This is very important, and collagen vascular diseases. Because I have seen one rheumatoid arthritis patient, and it was not specified in the pre-op orders, and we just made a corneal wound, and the corneal wound sealing was very poor post-op, and after 6 weeks, that patient landed up with the sterile melt of cornea. So don't take it casually. As a student, you should always remember what systemic problem patient is having and where you're planning for the incision. So incisions, by and large, what we used to make in a normal extracapsular cataract surgery was a curvy linear incision. But now, as I told you, it is more of the extension of the phaco. So we don't make a curvy linear, we just extend the phaco incision along the limb. And straight incisions are there when you are thinking that you are doing a SICS and the nucleus is very large, then you just make too relaxing and convert it into the larger incision. So this is an incision which we used to do for conventional extracapsular cataract surgery. And this is 8 to 10 millimeter, mostly uh, limbal or scleral incision. Clear corneal incisions were usually not done for ECCE. And this is 8 to 10 millimeter size. Now we have shifted to SICS and we make a scleral tunnel kind of. So it's 6 millimeter, 7 millimeter. It is a self-sealing incision. But in this case, you need to put the sutures to close this because this is not a self-sealing incision. And phacoemulsification, it's 3 millimeter incision only. And in case if you want to convert it, you can easily convert it from this side. So how to construct an incision? Normally, plane incision is the best incision in which we make a perpendicular incision, then we move anteriorly towards the corneal side, and then it is again a perpendicular incision with a microkeratome. So this is a planar incision, which is ideal, have a good valvular action used in all SICS. But in cases of phaco, we use a beveled incision in which we make a perpendicular groove and then just bevel it inside. So this has got a kind of, if you say, self-sealing properties. Just because it is small, it gets self-sealed. But if you make it a larger incision like this, it won't be a self-sealing incision, and you have to put the sutures in it. Wound construction. So perpendicular wound construction is practically gone. We don't construct perpendicular wound. We either construct 3-planar or beveled incision. Beveled incisions are easy to construct, but there, as I told you, if you are extending the incision, the tendency for wound gape might be there. So you have to put the suture. 3-planar incision are they have got very good valvular action, and they are self-sealing up to 6 millimeter. So types of capsulotomies. In today's scenario, it is mostly the continuous curvilinear capsular excess, or if this has been if you are not able to complete this, then you convert it into the can opener. Envelope was the previous when we used to do the conventional extracapsular cataract surgery. In cases of hypermature cataract, what we did, we just made an envelope kind of thing opening, and we used to take out the cataract from this. And the advantage of this was that you had a anterior capsule as a support system. In case if there is a PCR, you can keep a lens on the anterior capsule. But practically nowadays, you don't use this. Either you use can opener technique or you use continuous curvilinear capsulotomy. So whenever you're doing capsulotomy, this is one thing which decides the your surgical outcome. How much centered it is, what is the size of the capsular excess. So I always say, try to do it in a good visualization. A focus should be good. Because what happens is, if your focus is not good, then these like this step, you can't afford to miss it. So always keep a good focus. Better to do in the retroillumination. If it is not a very hard cataract or HMSC, retroillumination, you do it against the glow, and you will realize that you make a perfect capsular excess. This is the tip in IMSC cases where you can easily see the glow. And even if there is corneal scarring and all, that won't hamper your visualization of capsular excess. So what you do is, in can opener, you make with a 26 gauge needle, you make a small radial cuts. So these radial cuts, like, you'll keep on making these kind of cuts. So if you make very small cuts, the advantage is that you won't get the capsular tag. And the advantage of this technique is you can make a very large rexus. Like in hard cataracts, you need to make 6.5 millimeter. So you can, even at times, you can do it blindly if you're an experienced surgeon. If your pupil is not dilated, you can just do it blindly also. But in continuous curvilinear capsular excess, the proper visualization has to be done. And usually nowadays, what happens is people start doing from a side port. They start the capsular excess. And if capsular excess is complete, then they will start phaco. And if they find the capsule has extended, they will convert it into the can opener and then go for SICS or something. So that's what I said. Doing selective ECC have become very, very less. If you're aware, alert, and conscious what you're planning, then rarely you will land up in a situation where really you have to convert in ECC. The advantage of continuous curvilinear is that you won't have any tags in it. So when you are doing cortical aspiration, manipulation, everything, the IOL is well centered. In this cases, when you are doing this aspiration, then you may have the tags in it and you may accidentally pull the granules. So in which case would you like to do the can opener technique? It is mainly in hard, mature cataract with calcified capsule, or if your CCC is not complete and it has got extension, then only you go for can opener technique. And in today's world, this is the femto cataract capsulotomy. And if you'll see, it is somewhere attached. Looks like it has not been cut here. Actually, what this makes is tiny spots. They'll make a tiny spots here. And it is like multiple dots which get attached, and it is a capsulotomy. It's called as postal ticket. So if you see here, you may have a doubt that this capsule might be attached here. So in this case, you have to be very careful. You just pull the capsule towards centripetal. That is very important. Never give this kind of tangent movement because it may run away. So always pull it to the centripetal side. And this is a clear-cut free capsular access in case of femto. So as I told you, the technology has taken over, and now we get a well-centered, whatever size you want, a free floating capsule in HMSC. So this actually reduces our tension to at least 50%, 90% in the nucleus delivery. I don't want to discuss in length because SICS, in SICS, you will be explained in a better way what are the different nucleus technique. In extracapsular cataract surgery, what you do is you take out from this much big incision, and it is a pressure counter pressure technique. You just press it here, and counter pressure is given at 6 o'clock position, and the nucleus is delivered. And when you start cortical cleanup in these cases, you have to be very careful because you have made a can opener and which has got multiple tags. And when you do the cortical cleanup, you may accidentally, because the capsule is convex in these cases, it's the anterior chamber which is very shallow. Although we try to put the sutures beforehand so the chamber can be maintained. And if we have extended the phaco wound, what we can do is we can make two side ports and do the aspiration. We want a closed chamber aspiration because open chamber causes the convex posterior capsule and you may accidentally hold it. So, as I already told you that automated aspiration systems are better. Try to stick to the automated system. But in case if machine is not working, or in case you have to do with the manual system because there is a PCR and retractor is not available, then still I'll say close the wound as much as possible, make it a closed chamber, and then do it. Otherwise, the manual, in manual, there are very much chances that you may pull the capsule or you may cause the PCR. Whenever you are aspirating the cortex, always remember to maintain the chamber equilibrium and augment the red reflex, because now the nucleus has been taken off. So in all cataracts, you would be seeing the red reflex. So go in retroillumination, and you can clearly see the capsular excess margin here. Whichever method you have used, but you can see the capsular margin here. And always test for zenular capsular integrity also, because these are the complicated cases. You might have accidentally pulled the zenule, or the zenular descent might be there. So check for this before starting the aspiration. And focus should be just posterior to the capsular line. So this is a closed chamber where you are using a bimanual technique. The principle of cortex cleaning is engage, strip, and aspirate. So normally you go for the radial movements when you are aspirating the cortex. But in this case, in cases where the cortex is very sticky and it is subcapsular, then you need to move tangentially. And this is a case where you are aspirating with the Simcoe cannula. So it is a closed chamber. I say most of the time we try to maintain a closed chamber as much as possible. So as I already told you, open system, it's more difficult to perform, higher risk of endothelial damage. Blind cortex removal at fornices are more difficult. And the eye is hypotenuse. In closed system, it's the risk of endothelial damage is less, and it is easier to perform. Then in extracapsular cataract surgery, suturing is one important thing which you have to learn. And normally we don't suture the wound. So we, like, at one stage you become um, uh, your training becomes like faded off, that you're not suturing the wound at all. And then you suddenly realize that today you have to suture the wound. So suturing is one thing which makes you ambidextrous. Keep on practicing the suturing technique. So in suture, when you are putting the sutures on the wound, you have to make 3 points. Length, what would be the length of the suture? How to titrate the tightness, what would be the depth, which material needs to be used, and how you have to orient the suture. Length, usually we keep it 1.5 millimeter. And there is a compression zone around the suture length. So this suture, this compression zone is equal to the length of the suture. So if you're giving long suture, the compression zone would be more. And if you're giving the sutures very nearby, then they are overlapping in the compression zone, and that will cause with the rule astigmatism. So suturing the wound, you have to have two criteria. One is the wound should be properly sealed. The other is the minimum astigmatism needs to be induced by suturing. So that's why you need to take care of all these points, that it has to be 1.5 millimeter in length. It has to be like the compression zones shouldn't overlap, or they shouldn't be very apart. In this case, they are very distant suture. So the compression zone is not matching here. So you'll get against the rule astigmatism. In this case, the compression zone is equal to the length of the suture, and they are just touching each other, and you'll get minimal astigmatism in this. Then tightness, usually when you're working on microscope, you can see the folds on the cornea or dimple on the cornea. So you may see the dimple. Am I visible, sir? Hello? Hello?
Yes, slides are visible. Slides are visible.
Okay, sir. So what we need to know is the depth has to be 90%. It shouldn't be the whole thickness, because then you may get a suture track infection. The material what you use is, nowadays we use Tenno nylon suture, but Ato nylon was also used in, silk was used in few cases. Absorbable suture like Vicryl has also been tried, but it causes a lot of reaction and inflammatory reaction. Steel sutures were very kind of non-reactive sutures, but practically it's very difficult to tie them. So nowadays we use nylon tenue sutures, and the suturing technique has to be very perfect. The orientation of suture should be the first central suture should be vertical, and then there has to be the radial sutures. So this is the way you hold the needle at 2/3, 1/3 junction. Keep it perpendicular, and just take a three knots at first, and then 3:1:1. And suture tying practicing has to be done very regularly. This is one thing which gives you a best hand-eye coordination. This makes you ambidextrous. You can use that simple thermocol of suture, and which you can tie the sutures regularly. That will give you the maximum hand-eye coordination and a good suturing practice also. So how to convert a phaco into ECC? As it's simply, if you planned a phaco, you made a 3 mm wound and you found the rexus as extended and you just need to convert it. So just increase the corneal incision, and by seeing the size of the nucleus, and just take it out with the vectors. That's the technique, and then suture the wound, make it seal. So this is the post-op picture. The previous, the regular extracapsular cataract surgery, in which you used to put the suture, and nowadays it's so beautiful eye that you'll give a round reacting pupil with the incision. At times you can't even make it out where the incision is. So what were the disadvantages of extracapsular cataract extraction? It was iris prolapse, astigmatism, posterior capsular opacification. The wound sealing was not good. Endophthalmitis chances, and economic cost was higher because it was a frequent visit and a longer theater time with more number of glasses. So as we are coming closer to perfection, but still you can never be perfect. Perfection is not the way of existence. Growth is the way. Thank you.
Thank you so much for the concise but presentation, but it had all the important points that one needs to keep in mind when he or she is trying out the ECC. Sir, before we take any questions, any comments from the chairperson?
Yes, it was a very good presentation, madam. And actually, nowadays, when we started our journey of cataract surgery, I think so. All students, nowadays they start a journey from the phaco surgery. But in our initial days, when we started our journey, it was right from the intracapsular to the extracapsular, and then we were going. Now then we go to the phacoemulsification, and now to the femtosurgeries. But those who are very excellent, doing excellent extracapsular surgeries, they are doing a very good phaco surgeries. So because doing a good capsulorhexis and maintaining a anterior chamber and doing, I think so, the very good practice of suturing is also very important, as madam says, because when you are exposed to in phaco, when complication occurs and when you have to convert phaco into the extracapsular cataract surgery, and at that time when you are exposed to the suturing, then you are fumbled, or you make mistakes, or sometimes that at that time a lot of astigmatism occurs, and then you have to give a perfect result. Means after doing a good extracapsular surgery also, less amount of astigmatism is also a very important part. So I think that is also a very important point, was what madam has pointed out. So doing a good continuous suturing, and that is also a good part. I just want to ask madam that which amount, what in a non-dilating pupil, how do extracapsular cataract surgery has to be performed? Like, because nowadays all equipments are there, like BHAC-ring and pupil dilators are there. But in extracapsular cataract surgery, madam, can you give some
So,
light on?
if let's see, we have already put the iris hooks, dilated the pupil, we have done the rexes, and then now we are seeing that the nucleus is going down. So most of the time you land up in these kind of situations.
Yeah.
If you are like pre-planned, then you can simply do the sphincterotomies, or you can just pull with the Y pusher. This is
Yeah.
a simple way to take out from them. Otherwise, if you try to take the nucleus out from the small nucleus, would be a lot of iris injury. So it is better to do. In our days, we used to do the sphincterotomies. Now we do it with the Y pusher. We just relax some sphincters, and it gives a big dilated pupil. So the iris injury is minimal. If we have already put the iris hooks and you're in the state that you were doing the phaco in between, and now suddenly you have to change, so iris is already retracted, so you can take it out from that
Okay.
pupil.
Right. Because nowadays capsular hooks are also available. So in cases of a subluxated cataract or in between when there is a zonulolysis, you can put a capsular hooks also to strengthen that part of a capsule. So I think that also works well.
Ma'am, one couple of questions that have come up. One is when you're suturing the wound in ECCE, then is there any particular sequence in which the sutures are put, like the central one first, then the sides, and then come in
Yeah,
between?
I told you
Like,
the first has to be central, and then the radial sutures need to be put according to that. First you have to align the cornea from the middle, and then you have to give the radial sutures. So it is like first central suture, then you make one radial, and then both the sides again. You don't go from like one side, don't keep on going. You put a central suture, this side, then again this side. It has to be properly radially aligned.
thank
Okay.
you. And second is people want to know regarding timing of suture removal, as to what are the points that they need to check in the post-op visits, and then how do they time out their suture removal?
Yeah, actually, what happens is after 3 weeks, you do a keratometry. That is the best thing. Now, the pentacam is also available, but you do the keratometry. First, you get the refraction done without suture removal. Then you see which is the steep axis, which suture is tight. Then you selectively keep on removing the suture. You always don't remove the suture in single go. At times, you titrate one by one. You remove the suture. If suture is not loose or anything, then you can keep the suture for a longer period. And according to the steepness of the cornea, you remove the tight sutures first. So if
Thank
you
you.
have put because nowadays we don't put 5 sutures or kind of these. We hardly put 1, 2, or 3. Maximum 3 sutures are put. So either if you have not put a very good sutures, in cases if you have burned the wound in cases of hard cataract, or if patient is having rheumatoid, so yes, suture has not been aligned properly, you have just closed the wound kind of, then better to remove after 3 weeks all the sutures. But if you have put a beautiful 3 sutures which are properly, so then you see for keratometry which is the steeper meridian, you and take out the tight suture first, and then again you ask the patient to come after, and you can selectively remove the suture whenever you want. If the suture is not causing any reaction, it is not loose, it is not causing any astigmatism. So interrupted suture has got this advantage that you can selectively remove the suture. And if you find that suture has not been properly tied, it is better to remove the suture. And after 30 minutes, if you will do the K reading again, you will find that the astigmatism has settled down. You don't have to call the patient on the next visit. If the patient is coming, like you can just make a glasses prescription from them. Ask the patient to wait for half an hour after removing the suture, and the K reading, repeat the K reading, and you can prescribe the glasses to them.
And ma'am, what would be an ideal post-operative medication regime after an ECC?
I think if it is a complicated cataract, you would like to add some additional, otherwise steroid and antibiotic. Simple, what we prescribe in routine cataract surgery, we prescribe antibiotic for 10 days. steroids for 3 weeks. First 3 days, we put it 8 times a day, then 4 times a day. But in these cases, because you may expect a bit of reaction, a bit of corneal edema. So in these cases, you can titrate the steroids according to that. You may keep it for a longer time. You may keep it 6 times a day. You can add a cycloplegic. You can add a kind of a hypersol ointment if you find a lot of edema. So it's not at times it's a very beautiful, like HMSC case, you took out the nucleus at the right time, you extended, and you will find a round reacting pupil next day. So it's not ECC, it is the way you have handled the case. So this is important. It is not just you go for it's you have extended the wound, you have put 3 sutures, now you have to increase the drops. No, if it is a beautiful incision which was planned at the right time, you took out the nucleus at the right time, you put the lens in the sulcus, and you have put 1 or 2 sutures, it's fine. You just go for a normal routine phaco. But in case if it is edema or you're expecting a lot of reaction, add a cycloplegic. Steroid should be put more frequently, and adding a hypersol ointment, which will reduce the edema. So these are the only things we add. I don't add much of the things unless it's required.
Do you add normally oral antibiotics after an ECC?
Oral antibiotics is we have got for everybody. In our discharge card, it is for everybody, because you never know, patient might be having some tooth infection, some other infection nidus they are having. So we routinely give oral antibiotics for 3 or 5 days. That's our routine regime. So I don't increase it in these cases. It's like 3 or 5 days. That's our normal regime, even in phaco, because nowadays patients, they don't disclose their history very well. They might be having some tooth infection, and I have seen one patient who was having some root canal problem. 3 weeks, she kept on getting the AC reaction, and you didn't realize, then you realize what was the problem happening. So in India, you can't trust the patient much. So it's better to go for just for a sake of that, at least if somewhere any infective nidus is there, it's taken care of.
And you would allow a head bath after how many weeks?
That is after a week only. After a
Okay.
week mostly. After a week.
Okay. And then there's another question which asks that why is the incidence of PCO said to be higher in ECC cases as compared to maybe a phaco or something?
See, because one, the handling of the tissue is more, the reaction would be more, then PCO chances would be more. The second thing that I told you, that the capsule is convex. It's not, because you're doing the open chamber. If it is a closed chamber, then you can polish the capsule. But here it is a convex PC. So you can't polish it properly. So that's why the lens, what we call as the cells which are not dislodged properly. So you may get an early PCO. In closed chamber, you are able to polish the capsule very well because it becomes concave because of the pressure and all. So this is the reason why extracapsular have got more chances of PCO. And I told you, handling is one thing, more handling, more reaction, more inflammation, early PCO.
Thank you, ma'am. These were more or less all the questions. And anything from Dr. Garvita?
Madam, I just want to ask, in cases of corneal decompensations, especially in the Fuchs endothelial dystrophy cases, where we have to convert, or where there is a predisposed Fuchs endothelial dystrophy cases, where we have to do extracapsular cataract surgery, or hard cataracts, or mature cataracts, then what extra precautions we do take, or what we investigate preoperatively, especially?
We go for specular microscopy. The cell count has to be done. Use viscoat, and you have to be very generous in using viscoelastic. You shouldn't use it in miserly. The anterior chamber should always be formed. And usually, somehow by and large, I have seen these corneas are more flatter than the normal corneas. I don't know why. And the second thing is the chambers are very shallow. These kind of chambers are very shallow. So be liberal in using the viscoelastic and explain the patient properly. In spite of doing the best of the surgery, I've seen one patient in which I didn't use any power, practically nothing, but the DM folds were persisted for 3 months or something. 3 months, but it was kind of going in an early decompensation, but somehow we could revive it. So in spite of doing an uneventful surgery, so Fuchs, you have to keep your fingers crossed. The only thing what you can do is use a liberal viscoelastic, use viscoat, explain the patient, and chamber formation should be always good. If you're doing a phaco, take out one segment. Ideally, if a chamber, I always see the anterior chamber depth also on axial length.
True.
So if it's 2.5 or less, this case would be difficult to handle.
Yeah.
2.5 millimeter and less. So I check anterior chamber depth when I am checking the biometry. Nowadays, I make a routine. So because at times you do a very this is IMSC, you have done a cataract and suddenly you find next day why the DMF are there, and then you realize retrospectively you haven't checked the AC depth. While doing a phaco, you could realize.
Any role of preoperative giving intravenous mannitol to suppress?
Yeah, that is for axial lens. If the axial lens with shallow anterior chamber, I would like to give mannitol. I'd like to keep the vitreous condensed because that upthrust also makes a lot of difference. So I check for axial length also. If with axial length, the anterior chamber is also shallow, definitely I'll give mannitol. But if the axial length is normal and only the anterior chamber is shallow, then I like to use viscoat and I won't go for mannitol.
Right. Right. And I think so. That's what you suggested, that in all these patients of a very shallow anterior chamber, especially you should practice making a capsular access from the side port, especially because all these cases, when you practice it from the side port, then it will be very easier to do a capsular access. Because if you do from the main chamber, then a lot of viscoelastic, it rushes out of the main wound, and difficult for you to do a capsular access. So that practices also helps in all these cases.
Actually, capsular access needs to be learned from side port only. Because it shouldn't be. We our generation learned it from the main port, but now I'm a pediatric cataract surgeon also, so I don't have any problem doing with the rexis forceps.
We all are doing. So I think so now.
But it has to be done from the side port ideally. If it extends or something happens, you can just convert it into SICS, or that's the best thing you can do it.
Nowadays, all good, very good retina forceps and are available to.
Yes.
It goes from the side port and it converts to also. So instrumentations are good nowadays. Yes, Sudhanshu.
Yes, so we don't see any other questions. So
I have a question, just one. Regarding the suturing in cases of ECCE itself, let's say a patient has 3, 4, 5 sutures. So, ma'am very nicely explained how to remove them, how to titrate and then remove them one by one. But what I have struggled with initially is sometimes when we have a large number of sutures, patient, even though they have a clear central visual axis, perhaps due to the irregular astigmatism, it's not fully corrected. So the visual outcome in most of the cases is stuck at, let's say, 612, but not improving to 6.6, and even with pinhole. So how, ma'am, like if you could explain again how to exactly go about, like should we remove, because most of these surgeries have some complications. So early removal of sutures, or should we wait to remove these sutures? Let's say if there's a extension of rexis or something, and we cannot remove the sutures early and we have to wait. So how to go about that, ma'am?
So that's what I told you. Earliest we can remove is 3 weeks. But it is not always, because the manipulation has happened. So wound is not very healthy. Or it is a kind of, you have done some wound burn while doing a phaco. So the suture, you have to see it, whether the wound is approximated well or not. The examination of wound is very important. 3 weeks is the earliest period when we remove. If everything is clear, if you find no, it's not, the wound has not been approximated well, so then you can selectively, if you want to remove 1 or 2 sutures, but you can wait up to 6 weeks. Even we have removed the suture after 3 months also, if it was well tied and all. But in these cases, just because you haven't, the wound approximation is very, very important, because in these cases you won't find a very healthy wound. So 3 weeks is the most earliest when you can remove, but you can wait till 6 weeks also easily. when you're safe, and then you can remove. That's what I say. Explain the patient well. Explain that the sutures would be put. Explain that the vision won't be clear till 6 weeks. I always gave a window period. It will take 6 weeks, because see, expectation should, you might have done a very good surgery. That's what I'm saying. And there are a big dilated pupil in cases of patient who was taking Urimax, and he kept on complaining that I'm having photophobia. So if you haven't explained the patient well, so these cases have to be handled very differently. You have to explain them, and suture removal you can do even up to 6 weeks easily. That's not an issue. If it's not a loose suture, if it's not a reactive suture, you can just wait for the wound to heal completely, and then you can remove the suture.
Yes. Thank you.
So with that, we're coming towards the end of today's session. Dr. Tyagi ma'am, thank you so much for covering this topic so nicely, putting forth all the necessary and important points. Dr. Vadia sir, thank you for chairing the session. In fact, chairing the last few sessions of the iFocus. It was really great, learning from your experience. And then Dr. Garvita, thank you for coordinating everything so nicely. Any concluding
Thank you.
remarks from the chairman, sir?
Thank you very much, Dr. Subhranshu, and thank you very much, Dr. Tyagi madam. This was a very good topic, and I think so. Madam has covered very well. Basic extracapsular cataract surgery, what we have learned and what we have practiced it out. Now, as we are in the era of femto and cataract surgery, but we should not forget our basics. So I think so very well covered this topic. Thank you very much, madam. So now we can end up this session, Dr. Subhranshu. It was very nice talking to madam also. Thank you.
Thank you,
Thank
sir. Thank you so much to talk to you all. And we are like back to the extracapsular surgery when we used to do our camps and all that.
Yeah, very true.
So
We were
it
doing
was very
all
difficult
this
for
as well.
me to speak. So I once
Yeah.
you're trained, but speaking that thing is very difficult
Yeah, we
because
were.
now you're not practicing at all
I
extracapsular.
was doing.
Selectively you extend the
I was
incision.
doing a lot of envelope techniques, and I think so. One of the because I have done a lot of extracapsular cataract surgeries in camp also, and my favorite was the envelope technique because it was giving me so much security that even if there is a PC tear, I can put a lens on the entire capsule, and then
True.
I can do a yak capsulotomy afterwards. So
And we used to do a lot of HMSC cases that time.
yeah,
Lot of
exactly.
HMSC. IMSC was a luxury for us to practice
Yeah,
CCC on
exactly.
those cases.
And that was the so simple one because at that time we can put that lenses in the sulcus also. So
Also.
PMMA lenses were available at that time to us also. So we can put that lenses. But nowadays, I think so. So nowadays, actually, if you ask new generations and this new all budding ophthalmologists, they don't know what is envelope actually. If you ask them to
Actually,
convert,
true.
and we convert that, they don't know how to convert that envelope into rexes.
Rexis. True.
So
We
that was
learned
a,
the Rexis that way only.
yeah,
Lot
we
of
learned
times.
the rexes that way only, exactly. That you cut and then you convert that into the rexes. So nowadays, so all that era has passed actually, but it was a good to learn from all these things actually. It's a nice,
It was a revision of our own
yeah,
past.
very true, very true. Thank you, madam. Thank you.
Thank
But
you, sir. Thank you. So nice to speak to you all.
thank
Thank
you,
you.
Thank you. Thank you, sir.
Thank you, everyone.
thank you,
Thank you, Dr.
thank you,
Kanak ma'am,
Varvida.
for such
Thank
a
you.
Thank you,
wonderful session.
Kavita.
Thank you, please. Thank you, Singupta sir. I would just like to also highlight the physical eye focus that is happening in Hyderabad from June 9 to June 16, 2024. Registration is limited to 300 candidates and early bird registration closes soon. So I would just like this opportunity to invite everyone to register online for the event. Thank you, everyone. Thank you, sir. Thank you, ma'am.
Thank you.
Thank you.